Good afternoon and welcome to today's webinar, Program Development Strategy, hosted by the Blue Shield of California Foundation. This is the first webinar in a four-part learning series on local programs for the remaining uninsured. My name is Bonnie Madura and I am working with Blue Shield of California Foundation on this learning series. I will be your moderator for this webinar. Before we get started, I want to go through a few housekeeping items. To avoid background noise, all callers will be automatically muted throughout the webinar. If you would like to ask a question during the course of the presentation, please do so in the question window on your screen. We will do our best to address your questions at the end of the presentation. Also, just remember that today's presentation is being recorded and will be archived in the Foundation's website. Please tell your colleagues who were unable to attend so that they can still benefit from the presentation and the discussion. Now, I'd like to turn it over to Carolina Gutierrez, Program Associate from the Blue Shield of California Foundation, to say a few words. Carolina?
Thank you, Bonnie, and thank you, first of all, to all of the speakers. As Bonnie mentioned, my name is Carolina Gutierrez. I work with Blue Shield of California Foundation, overseeing some of the work that you will hear about today. Our foundation has supported efforts to address the needs of the uninsured across time and through several changes to the healthcare landscape. And most recently, as many of you know, the Affordable Care Act has significantly reduced the number of uninsured throughout California. What we also know is that today and in the coming years, there will still be several million Californians who remain without healthcare coverage. And projections show that up to half of those will be undocumented immigrants. So in the absence of a federal or state policy that addresses these persistent coverage and affordability challenges, California's counties have had to create approaches that meet the healthcare needs of the remaining uninsured. Last fall, the foundation awarded a group of grants to communities across the state in order to help them design, plan, and implement programs that emphasize prevention, primary care, and health management for these uninsured patients and undocumented immigrants. And today you will hear from 3 such communities. Thank you all for your interest in supporting these issues alongside the fantastic partners that you will hear from shortly. And please enjoy this webinar.
Thank you, Carolina. I'd like to take a moment now to introduce you to our speakers for this webinar. First, we have Alvaro Fuentes, Executive Director of Community Clinic Consortium of Contra, Costa, and Solano counties. After Alvaro, we will hear from Susie Shoup, CEO of Redwood Community Health Coalition, and Brian Vaughn, the Director of Health Policy, Planning, and Evaluation for Sonoma County Department of Health Services. After Susie and Brian, we will hear Julie Michaels, a policy analyst with Marin County Health and Human Services. So let's get started. Alvaro, why don't you kick us off?
All right, with pleasure. Good afternoon. My name is Alvaro Fuentes. I'm the Executive Director of the Community Clinic Consortium of Contra, Costa, and Solano County. This afternoon, I'll be talking about our experience with addressing the issue of the remaining uninsured in Contra Costa County, with a particular emphasis on how we were able to build an effective collaborative to help guide this work. I'll first start off by giving you a little context about the history of the issue relative to our county. Next slide. Okay, so back in 2009, Contra Costa County Board of Supervisors, as a result of the financial difficulties that we were all facing nationally, they decided to eliminate access to primary care services for approximately 5,500 undocumented adults. They estimated that they would save a projected $6 million as a result of this action. Now, children remain covered. As a result of this decision, the community health centers became the primary source of health care for this population. Notwithstanding the transition, they obviously faced a large financial impact as a result, and the total number of individuals that were impacted actually exceeded the 5,500 that were estimated, and it was well over 10,000. So through a lot of advocacy work that the consortium did, we were able to generate funding from the county for health centers for a period of a few years. The funding that was provided was through grants, and they covered basic primary care services, but there was really no coordination with any other organizations or stakeholders beyond the community health centers. And so after a few years of the county providing this funding to the community health centers, they realized that this was not sustainable. And quite frankly, they decided that there needed to be a broader systemic approach to the issue. And so they needed and wanted hospitals to take ownership over this issue as well. So really, it kind of put us in a position where we had to decide how we were going to be able to address this issue. And so I started working with a few key partners that I had who were representing the county and the local hospitals. So we formed a small, I'll call it behind-the-scenes work group that really helped to conceptualize the planning process that we wanted to launch into. And so through that work with that work group, we were able to identify and conceptualize a path for a more formal planning process that would engage an existing collaborative made up of a broad range of stakeholders from around the county. We realized that in order for us to be successful in addressing this issue, we needed to build trust among the existing collaborative and really build bridges to some of those and break down some of the walls to some of the silos that had existed or have existed in this county for some time now. And so we wanted to make sure that we were really transparent about the process, and as I said, that folks had ownership over what we were doing. So now, the slide that you have before you really emphasizes 4 different set of stakeholders. So obviously, community health centers were focal to this, as well as the county leadership. That includes all the board of supervisors, health services, which includes the director of health services, and the CEO of the county health plan. Local hospitals were engaged as well, and so there are 3 local hospitals in our county. Each was really critical to helping us establish the kind of collaborative that we needed in order for us to be successful. Now, community advocates were an integral part of this effort as well. And by community, I'm using a broad umbrella to cover community advocates because really what we did was amazing. We were able to not only engage local stakeholders, but we also expanded or developed a campaign that really engaged stakeholders from around the state. And they included some elected officials as well as some statewide organizations like the California Primary Care Association, as well as Health Access. And so we knew that we had a lot of the pieces in place to be able to address or to be able to launch into a planning process that would help us identify strategies that we could, as a collective, be able to build on and decide really what was best for our community. Some of the things that we had really working against us was that in this particular county, historically, there hasn't been a lot of direct engagement with community-based organizations in the way that other counties model. And so given that history, we knew that we had to really build on any kind of collaborative work that we had done in the past. And so we did have an existing body of folks that were working on access issues. And though that group was meeting somewhat regularly, we knew that this was an opportunity for us to really present a project that folks could really galvanize around and really help us to build something meaningful. And so this particular group was known as the Access to Care Stakeholders Group, and it was made up of county representatives, community health centers, hospitals, and a few other organizations. When we presented this opportunity to this group, we got a great response. And the reason why we were able to do that, quite frankly, is because the small group of folks that were working behind the scenes were making a lot of calls, really working with their own constituents to make sure that we had the buy-in that was necessary in order for us to be able to move forward with any kind of planning process. Once we were able to plant those seeds and folks became motivated and interested in really wanting to see what we could do collectively, I think that's when things started really taking off. That's right around the time when this concept was presented to the Blue Shield Foundation, and they really, excuse me, believed in the model that we were presenting, and as a result, we were able to really begin with building on our momentum and all of the seeds that were planted with each of our respective constituents to make sure that we had the necessary buy-in from key folks so that we could be successful. It was a tremendous amount of work to be able to get that buy-in. It was, we counted on a lot of our own personal relationships that we had established over years, and certainly it was, I think, at the end of the day, what has proven to allow us to move forward with not only a successful planning process, but also move forward to where we're at now in terms of implementing a pilot program that we could look towards building on in the coming years. So this is where we are now. As of last November, when we started implementing our program, we were able to enroll, we're about 2,600 people that we've enrolled into our program now. And as I said a minute ago, this is a pilot program where we are capping it at 3,000 folks that we are targeting. And as you can imagine, that's because of the limited funding that we have available. And I should also mention that the funding that we were able to generate for this pilot was through a combination of county and hospital funding. And so we were able to establish an oversight committee that is essentially made up of the same collaborative that helped us to launch the planning process. That a subset of that collaborative has, as we're calling it, a provider work group, has been meeting regularly, continues to meet regularly, and they are helping us to establish the necessary framework for an evaluation. And then we are continuing to meet with our community advocates. We actually were able to form a coalition around this work that we call the One Contra Costa Coalition, that's made up of the broad range of community advocates that I mentioned earlier. And again, this is a broad umbrella that includes local, regional folks, as well as partners statewide. Now, what's next? Naturally, since this is established as a pilot, we need to focus on what we can do to develop a sustainable program. And by that, I mean we need to extend the scope of services that we currently offer now beyond primary care and some ancillary services. We need to address and build on our ability to share data among the different providers that make up the provider network in our program. That includes the community health centers, with some referrals that are coming in from the hospitals and the county. We want to be able to ensure that the network of folks, the network providers are available to able to meet the demand. We know that if right now we're serving 3,000 folks, we know that there are probably well over 10,000 or 15,000 that are impacted in this counties, so we want to make sure that we have a network that is able to meet the needs of not only that population, but also all the other insured patients. And we need to be able to make sure we have an evaluation component that allows us to track and really articulate the impact of a project like this, because I think that's what's going to be really critical in helping us to build on the momentum that we've already established among the community health centers, the county, hospitals, and all of the other advocates that have been supporting our work. Thank you.
Great, thank you, Alvaro. Now let's turn it over to Susie and Brian from Sonoma County to let us know what's going on in their community.
Hello, this is Susie Shoup. I'm the CEO at Redwood Community Health Coalition. It's wonderful to have a chance to talk about the rich history of work on the remaining uninsured to meet the health needs of the remaining uninsured in Sonoma County. The work has been going on for a long time here. You can go ahead and advance to the next slide. And you'll see here a bit of the timeline of when this work started. We started back in the late 1990s. There were multiple efforts. Many people in Sonoma County at that time, including hospitals and community foundation and First Five and on and on and on, became concerned about the increasing number, particularly of uninsured kids, but of the uninsured in general and the impact on the community. And actually multiple efforts started simultaneously, and I'll talk about that in a minute. But just to give you a brief look at the timeline, we started working on this right around 2000, and then in 2004, we established the Children's Health Initiative under the name of Healthy Kids of Sonoma County. In 2005, we launched a Healthy Kids product and then began providing that coverage to children in Sonoma County through Medi-Cal, Healthy Families, and Healthy Kids. And then in 2010, that transitioned over to Redwood Community Health Coalition. The county had been the lead agency basically doing the administration of that program. It transferred over to RCHC at that point. And then in 2015, we broadened the work of that group into what is now called Covered Sonoma. So just a little bit more about the history of Healthy Kids, or our Children's Health Initiative. During the course of its existence since 2004, Healthy Kids has served more than 25,000 children, getting them access to comprehensive health coverage. So we have really a rich history of this, and that we were successful in doing that because of the incredible collaboration and partnership between various entities, many of the same types of entities that Alvaro mentioned. And Redwood Community Health Coalition, which is the consortium of community clinics, all of the community clinics, United Way, Catholic Charities, Health and Human Services, all of these entities, including the hospitals, came together, rolled up their sleeves, and really got to work to figure out how do we crack this nut, and really ponied up their organizational resources and actual dollars to start to address the remaining uninsured problem. Well, at that time, the uninsured problem. So it's been a long and rich history, as I say, and we are continuing that now as Covered Sonoma. So, and something that Alvaro mentioned, I think, has really quite important in the success of our early work in Sonoma County, and that's developing a real community engagement, and really in our case it was a marketing campaign. We used every avenue that you can think of. You know, we had marketing specialists help us to sort of package the messages. We did media, we did all kinds of events in the community. We hosted house parties, and I mean there was every possible kind of outreach that you could do to mobilize the community behind the idea of addressing the uninsured issue. And it was very, very successful, and I think now we have the benefit of having done that because there's real commitment across the county to the population that we're trying to serve here. You can advance the slide. So just a little bit now that we're in 2015, you know, this Healthy Kids Collaborative has been meeting these last 15 years or so more. Yeah, I guess it's about 15. And it's after the ACA, it became clear to us that our scope needed to broaden, that it was time to begin addressing the population as a whole and the remaining uninsured, and so we changed our name to Covered Sonoma and have really reinvigorated the existing coalition. It's comprised of many of those same organizations and new ones now, and we have throughout this period been putting out there robust enrollment efforts, and we used the experience of the open enrollments during the expansion of the ACA as an opportunity to even increase our collaborative work together. So at the end of 2015, Covered Sonoma went through an extensive strategic planning process. We knew we needed to broaden our mission, but we needed to lay out exactly what our priorities were. So you see here in blue the priorities that we've picked to focus on in the first year to address the remaining uninsured and access to care issues. But we still continue to work and develop internment and medical home linkage and health insurance literacy, but those just aren't our major priorities in this year. So all of us brings this really a step closer to having health for all in Sonoma County. And just to summarize here what we're currently doing, we are actively pursuing addressing our remaining uninsured population, and Brian Vaughn from the Health Department in Sonoma County will be talking in a minute about the research that we're doing that will form the basis for our plan to solve this problem. We also continue to have coordinated efforts around enrollment, in particular the expansion of Medi-Cal for children who are undocumented. So our coalition has a very tight work group that is combining our efforts and trying to make either the transition or enrollment of kids into their new Medi-Cal coverage as smooth as possible. And of course, we continue to do work together collaboratively around enrolling DACA individuals in Medi-Cal.
Great. I think this is where I jump in. So this is Brian
That's
Vaughn.
where you jump in, Brian.
Thanks. So this is Brian Vaughn with the Sonoma County Department of Health Services. So I have the pleasure today to talk a little bit about dovetailing off of what Susie was talking about in regards to the remaining uninsured priority for Covered Sonoma. So we had the pleasure a little over 2 years ago, well, the county about 4 years ago received a large community transformation grant from the CDC, and as part of that funding, we commissioned what we understand to be kind of the only one of its kind actual local that went out. It did some really deep dives into the communities of farm workers, looking at a variety of their health issues broadly, not just their physical health, but also looking at those social determinants of health. Based on that work, and with Covered Sonoma kind of formulating around those 4 new pillars, we had some success with that farm worker survey and driving that conversation about what their health looks like, and more importantly, how we're going to address. So wanting to be a data-driven entity, and obviously a data-informed practice here in public health in our health services department, we thought a great place to start, at least when talking about covering the uninsured at large, was to really go out and do a deep data dive into that population. This proposal, and we're kindly funded by the Blue Shield Foundation, to really look at this quote-unquote, undocumented undocumented residual uninsured population at large with these data objectives that you see on the slide here. So one, really kind of very basically, just determine the demographics of the remaining uninsured in our county. So what does that even look like? Knowing that those numbers are kind of really hard to find. So we've developed some proxies using really already available data through the ACS survey and census data. From there, we're looking to identify high-level disparities in healthcare access and utilization using the California Health Information Survey, using a special file there, really kind of now drilling down one step deeper and saying, okay, what are the healthcare access, what are people presenting with at the clinical level? And then really the big pieces of this study were to then actually go in and look at clinic data itself. So working Susie and her team at Redwood Community Health Centers, diving down into the patient level data and their utilization and their e-records to really figure out, okay, can we identify that population within the subgroup that's going to the FQHCs and the clinics, and then pull them out and see what are their particular utilization patterns. With really this idea of, well, if we're going to cover them, then we need to have some data around what's that going to cost, what services do they need, and this can really form the basis of any sort of coverage that we want to do moving forward, and more importantly, moving beyond coverage, really getting them in to the services, having access and utilization, which is really the end goal of all of this. And then also we went back out and broadened our survey and worked with our local organizations to do another deep dive into that bigger community beyond the farm workers, doing a really extensive survey looking at access to health care, dental care, and other mental health services, and documenting from the people themselves what their health issues are, where they're going to seek care, if they're going to seek care, and a lot of rich information there regarding their broad health needs. So just a little bit of an example of what we're looking at. So regarding the CHIS data, that's the California Health Information Survey, we accessed a special file and used some modeling that we had seen around that had been used before. We kind of made some assumptions around who the undocumented immigrant populations are. We used kind of this proxy of a non-citizen with no green card. Again, there's no perfect measure for this, but we thought that that was at least a close approximation. And really, as you can see here, looked at the measures of where do people go when they get sick? Are they delaying care and receiving prescription drugs? Did they even go and have a physician visit in any given year? And what are they using around the emergency department? So if we go to the next slide, we can see some of the preliminary findings. We're still in the middle of this now and going through particularly the clinic data. But here you can kind of see just a quick snapshot of some of the information that we're getting. And not surprising, most of this, you can see kind of big disparities, right, between what we're categorizing as those undocumented immigrants and those permanent residents. Really stark differences in their insurance rates, their self-reported health status, delays in getting healthcare services, and a lot more on this. So we're finding some rich data. We're still kind of wrestling now because, no data set and no findings are completely clean. We're really wrestling with these preliminary findings to figure out how this would affect and what it would mean for any sort of coverage moving forward. So then getting into kind of what we think is the even richer data is really that the analysis we're doing on the FQHC health clinic data. So we're looking at, again, de-identified patient-level data that's been provided in our partnership with the Redwood Community Health Centers, and looking at data between January 1st for one full calendar year, January 1st to December 31st for 2015 at 4 of the big clinics, and really going through, again, those health records. And trying to tease out to the extent possible who may be uninsured, knowing that that's not actually a clinical record that's documented, and then figuring out what are their utilization rates and what that looks like. So again, we're in the middle of this. The preliminary findings have been interesting. Again, some difficulty in identifying who is the who, but nonetheless, I think we feel confident we're gonna find some really rich data that's gonna help us moving forward. And then on the survey side, we just completed finishing the surveys. Sorry, this is more on the clinic data. So we're looking looking at a total of over 50,000 records that we're kind of sifting through now. But on the survey side, we were able to conduct about 282 surveys, which was actually pretty good for us. And these were of people in the county over 18 who lived in the county and were either Mexican or of Central American descent and were a non-citizen without a green card. So the same proxies we were kind of using for the health information survey data. It was a respondent-driven sampling and a convenient sampling, so some of the generalizability should be taken with a grain of salt, but nonetheless, with that number of survey respondents, we feel pretty confident that the data is going to be at least accurate to the population as a whole. And again, looked at healthcare access and utilization, even more so than just whether they had insurance coverage or not, but are they even, if they had it coverage, were they even accessing and utilizing that? And then really trying to identify the big things for us just in regards to barriers, knowing that they do have access right through the clinic. So what are those key barriers that any campaign will need to address if we're going to go out and figure out how we serve them? So again, the data collection was just finished, but we are confident that we figure we'll have a final report out in the next probably 2 months, and will be kind of, as Susie mentioned, a basis for how we talk about these issues and how we talk about, more importantly, about coverage and access and utilization moving forward. So some of the very preliminary findings that we're seeing, nothing surprising, that non-citizens are the largest here for the remaining uninsured in Sonoma County. In keeping with what we found in our farm worker survey, that there's real deep disparities between undocumented and permanent residents here in the county, and that the undocumented immigrants are obviously receiving much fewer services even at the FQHCs, and that there may be even particularly more disparities having with subpopulations, again using our farm worker health survey as kind of the basis for that. And that'll conclude my piece. So I think we're going to convert over to Julie Michaels, right, from Marin County.
Great. Thank you, Brian, and thank you, Susie. And Julie, right before you begin, just let me give everyone a reminder that if you have questions as we go along, please use the question box on the GoToWebinar control panel, and we will use those questions after Julie speaks. So let me now turn it over to Julie to tell us a little bit about what's happening in Marin County.
Thank you, Bonnie. My name is Julie Michaels, and I'm a policy analyst with Marin County Health and Human Services. I'm going to speak with you about the Marin Access to Care Collaborative, or MACC as we call it, and also a little bit about our data gathering efforts to date. Our collaborative is comprised of our major partners for working with the remaining uninsured. The organizations you see here on the screen, we've worked with on many projects over the years for the underserved populations. But for this specific collaborative, we convened them last fall for the purpose of planning coverage options for the remaining uninsured. So this collaborative is led by our Health Services Director, Dr. Grant Colfax. Our Public Health Officer, Dr. Matt Willis, is on our planning team. I'm the project lead, and Allison Clayton is our FQHC advisor. The Marin Community Foundation is an important partner in our planning process. Sharon Vicaria has worked closely with us to obtain data, as you'll see later, for our planning process. And our managed care organization, Partnership Health Plan of California, is at the table, as well as our faith-based organization, Marin Organizing Committee. All 4 of our federally qualified health centers are working with us. That includes Coastal Health Alliance, Marin City Health and Wellness Clinic, Marin Community Clinics, and Ritter Center Health Clinic. We have participation from CBOs throughout our county who work with this population, and that includes Canal Alliance, Novato Human Needs, Operation Access, Rotacare Free Clinic, and West Marin Community Services. All 3 of our hospital systems are at the table helping us to identify viable options for coverage, and that includes Kaiser, Marin General Hospital, and Novato Community Hospital. Bobby Wunsch is also guiding us in this process that we started last fall, and we're now just beginning to define coverage options available. And in terms of our quantitative data analysis, It was funded by the Marin Community Foundation and performed by Jared Sanchez of USC, and he used 2009 through 2013 American Community Survey data. I'll be presenting a brief overview of some of his findings. If you'd like more information on his methodology, please contact me and I can get that to you. So the Marin Access to Care Collaborative decided to focus on the undocumented adult population under 139% of the federal poverty level. The rationale for choosing this specific population is that they don't have any other options for coverage because of their immigration status. We're focusing on that specific definition of the remaining uninsured. The analysis suggests that we have about 4,000 people who fit into that category. Most, or 96%, are under 45 years of age, so it's a pretty young population. And the median wage earned by this population is just over $16,000 a year. So we have some demographic information on race, ethnicity, language, and education of this population. As you can see in the first set of bars, 92% of the population is Latino. The next set of bars in the middle there describes the language ability, and it shows that 15% do not speak English, 5% speak only English, 45% speak English well or very well, and 36% do not speak English well. The last set of bars is talking about education. We know that 54% of the population has less than a high school diploma. About a third have graduated high school. 9% have some college, and 3% have bachelor's degrees. We also wanted to learn about the health insurance status of the population. You can see from the first bar that 56% report having no health insurance, and 23% report public health insurance, which we believe is emergency Medi-Cal. So combined, this means that almost 80% of the population doesn't have a regular source of health insurance. Another 21% reported having private health insurance. Our qualitative data was gathered through focus groups, and these focus groups were funded by the Marin Community Foundation. We had an excellent facilitator, Selena Polson, who did bilingual groups, and then she analyzed the data, which we just heard this morning. In February and March of this year, the 4 focus groups were conducted with a total of 50 Spanish-speaking residents of Marin County. The focus groups were hosted by community-based organizations located in Novato, in Point Reyes, in San Rafael, and in the Canal. The groups contained between 10 and 16 adults of various ages and genders. Some were parents and some were not. Between 60 and 75% were uninsured or had emergency Medi-Cal only. And there are some key findings from our questions. The focus group questions covered 5 main areas, and I'll review each of the areas and some highlighted key findings. For health-seeking behaviors, we asked about health-seeking behaviors. About half of the participants had a chronic disease, and they did not obtain consistent care for this condition. They cited cost of care as a barrier to consistent treatment for their chronic disease, and many reported waiting to seek care until their symptoms were extreme. When asked about how they experienced accessing care, the second question, they reported that a lack of providers and a lack of funding for diagnostics affected the quality of care. They identified clinic overcrowding, long wait lines, rushed visits, and inability of providers to access needed diagnostic tools as some of the underlying issues. They think that provider retention is important and it's an issue for them, and most are satisfied with care if they're able to see the same provider over time. In terms of unmet needs, they report that cost is a deterrent to receiving diagnostics, and some people reported paying in the hundreds to thousands for diagnostics, including sonograms, MRIs, and blood panels. Participants also reported that cost is a deterrent for seeking dental care, and most reported that they did not receive preventive dental care. They said that they feel they must be an advocate for themselves and for their families in order to receive adequate care. When asked about improving care, they said that they want to see pro bono medical services expanded. Road to Care Free Clinic was viewed as very effective, and they had a strong interest in receiving healthcare education, tools, and counseling from their providers. Lastly, in terms of healthcare priorities, participants wanted a comprehensive coverage plan that included dental, primary care, specialty care, prescription coverage. They preferred a fixed cost that is tied to their income after expenses. And they said that they feel that the current sliding scale doesn't work for them because it doesn't take into account their expenses. That is a summary of our collaboration and our data gathering to date. And I think we're moving on to questions now.
Great. Thank you, Julie, and also again to Brian, Susie, and Alvaro for your insights and taking the time today to share with us your learnings about what's been happening in your community related to the remaining uninsured. We will now turn and open things up for questions. Just as a reminder, if you'd like to ask a question, you can do so in the control panel on your screen, and unless specified directly to a specific participant, we'll distribute each question to the most appropriate speaker to answer. So we will begin. Submit your questions. First, I'd like to start, and I'll direct this to Alvaro and Susie. I think as you went through your presentation, you alluded that both of your communities have had a long-standing history of engaging stakeholders and bringing folks together in a collaborative manner. Based on your experience, I wonder what you might offer to other communities across the state where this collaborative nature or this long sort of standing history of working together with one another may not be there, or it may be a little bit longer time frame to begin working on that. So Alvaro, let me start with you, and then we'll go to Susie.
Okay, so I should say that in Contra Costa County, while the health centers had been working with the county to some extent in a collaborative nature, I think there was opportunities to really build on that. And this particular issue, you can imagine, was certainly political in nature, as you can imagine, given the load. So I think one of the things that we had to focus on to really help us build on the work that we'd done in the past was really making sure that we were talking to the right people, that and by that I mean the Director of Health Services, and that we had his buy-in as it relates to this work, and that we were able to identify a champion on the board to be able to help us navigate the board level. And then certainly at the hospitals, we needed to make sure that while they were engaged and had been terrific partners, that they obviously saw the value and in doing this from a collaborative standpoint. And so it was a lot of, as I said during my presentation, a lot of behind the scenes conversations to really get folks motivated enough to ramp up the level of work that we were doing, recognizing that we were taking it from a collaborative that was established to something that was looking at a systemic issue with a lot of political implications, to really essentially be more sophisticated in terms of how we were looking at this particular issue, and really giving us something to build on for other future opportunities.
This is Susie. I'll add a little bit to what Alvaro said. Back when we started working on uninsured issues in the early 2000s, as I mentioned, we had a couple of different groups that were working simultaneously on this. One was a community-driven collaborative, mostly with community-based organizations and advocates, and we had some very passionate physicians and pediatricians who were part of that group. So it had a very, and a lot of community groups on there too. It had a very grassroots element to it that helped us. Simultaneously, there was a group called Sonoma Health Alliance, which was a leadership group, a very grass tops, if you will, effort of the hospital leaders who had a subcommittee that was interested in this topic as well. And so when we realized that there were two groups going on simultaneously, we merged together, and we had this fantastic coalition that had a lot of relationships already in place. But to just underscore what Alvaro said, even with all that, we had to really get out there and have a lot of one-on-one individual relationship building meetings with people, and eventually get the key stakeholders into a room together to really explore the issue. And what does it really mean for our county not to have all of our residents insured? And it sometimes took some arm bending and arm twisting to get them in a room together to do that. I'll just add also, as Alvaro said, having one or two key champions was key. We had the public health officer, Dr. Marin Gonzalez at that time, who really had a lot of, held a lot of sway in the county and had the respect of many, many people in the health world. And I think that helped to build the relationships and the strength that was behind our coalition.
Great. And let me just ask Julie, too, any sort of lessons from MACC that you might offer to others on the call?
Well, Alvaro came to speak with us, and they're a little further along than we are since our collaborative began in November. So we're just starting to get to the place where we're really looking at the options available and what people can bring to the table. So we're a little earlier in the process.
Great. Okay, the next question I think I will direct to Brian, and it has to do with the undocumented farm workers and sort of looking at who they are and their needs. And this question focuses on, farm workers tending to be a very heterogeneous population, ethnically speaking, in terms of those that speak mixed sex, Triqui, etc. Did you look at your sample sort of by this breakdown? And if so, sort of what implications might that have in terms of heterogeneity among the population you lack versus transferability to a broader undocumented population?
Yeah, that's a great question. I don't, in the end, we probably didn't do enough sampling to separate out by those subgroups. And I should, our caveat is always is that our agricultural industry is a little bit different here in Sonoma than, say, across the particularly the state. That because our predominant crop is wine and wine grapes, that it has a little bit of a different feel than it does, say, in the Central Valley, only because they tend to pay a little bit higher wages. I mean, one of the big findings we found actually in the county, which was actually pretty surprising for us, was that most of the agricultural workers live here year-round, that they're not migrating from crop to crop. And then that's some of the needs of the vineyards themselves, too, about ongoing maintenance and some of the care that they do. So we weren't able to dive down as deep, but nonetheless, the disparities that we did find as a whole were really kind of an eye-opener, right? Again, nothing shocking, but to actually have the data, to be able to put it out there, it has somewhat been able to allow us to change the conversation, because everyone knew that there were disparities out there. We've been fairly successful in when we put numbers to it, that for whatever reason, that has been a big trigger for getting moving stuff forward. We also saw this when we published our portrait of Sonoma County, which was looking at disparities across the county as a whole. Just having that data and being able to show it has been really powerful. And I think that's one of the hopes of the research we're doing here with our Blue Shield grant is to really put some, we could do all of this and cover the remaining uninsured without this study, to be frank, and some places are moving forward, and that's great. But I think to be able to have that rich data, it does extend conversations and allows a little bit more clarity for what that looks like.
Great, thank you. And I'll direct this next one to you too, because it does deal with the survey as well, or the data analysis. In terms of sort of why you looked at SHIS, sort of why you use SHIS for some and ACS for others, and not just use SHIS data only.
Yeah, I think it's just the difference in what is available where, and I think for us, if we could find some consistency, even if there was similar data between the two data sets that are already available, I think that's what we're looking for. Again, because no one is technically categorizing an undocumented immigrant versus not. We've had to use, in some cases, a lot of proxies, a lot of assumptions. So actually, we're looking in some ways to compare the data across to see where it does match, because that is a lot more confident. As we're looking through the survey, the clinic data, and then the national data, being able to tease out those subpopulations is tricky. So actually being able to have these comparison groups where there is similar data across the data set has been at least somewhat helpful in guaranteeing, or at least ensuring us that at least what we're finding in one data set may be consistent and we have a little bit more confidence with it.
Thank you. So I'll direct this next question to Julie, to you, and to Brian, of sort of talking about with this, the data analyses that you both have done in your communities. What is next with the data you're gathering? Are you going to be using it to help inform program design? Are you going to be using it to help build political buy-in? Can you talk a little bit about sort of what you intend to do with the data you've collected in a series of next steps?
Sure.
Julie, you want to start
with that? Yeah. Well, today we started that process by really looking at what the consumers were saying about their needs. As we look at the options that are available to us, we're using that screen of what would really meet those needs from what we've heard from our focus groups. And we've also are in the process of asking our FQHCs to bring in some data on their uninsured and kind of look at that in comparison with the USC data to make sure that we're on track. And I think, we need to know the N approximately, and then kind of look at the money available and the needs of the consumers and put all that together to come up with the most viable coverage option that we can.
And I'll dovetail on that. I mean, we had a separate proposal that was actually included initially in what we were proposing to do with our current study, was to now extend the findings and do some fiscal analysis, right? So the needs, where the gaps are, and then being able to take that data and add fiscal data over it. So what would be the cost of providing this service based on the needs that we're identifying? Why are people going to the clinic now? What are the particular areas of concern? And then the big question, right, is how much it would cost to provide them something? And having that data and using that, I think, would just, again, adds to the conversation and allows us to put more firm dollars behind what we're talking about when we're talking about coverage. And again, for a county that doesn't have a whole lot of money right now to spend on this, I think any way we can kind of capture that and have some confidence when we go and do have these conversations is really going to help us.
Great. So Julie, I think this question might be directed to you. There's a question about the observation that sliding scale may not be working, and sort of different perspectives, whether it's the scale is too high or it doesn't adequately differentiate between people of similar incomes but different expenses. Can you elaborate on that comment?
Sure. Yeah, the focus group, the report back from the focus group was that folks thought that creating based only on income didn't take into account all of their expenses, and that it became unfair because the expenses were large and made the sliding scale fee not affordable for them. There were also comments that some people who knew how to lie about their income got away with paying less, and so there's just a general unfairness. Like if somebody who makes more money can pay less than me, it's not fair. And so these are some of the comments that came out of the focus group. So that's why I think what they're saying is just give us a fixed dollar amount rather than sliding scale on something that we don't really think is fair. Make it a fixed amount so that we understand it and we understand our total cost. Does that answer the question?
I think so. This, I will open it up to whoever will want to take it. And it's a question posed probably more for the analyses, but I think really is relevant to any of you around the issue of churning and sort of folks that move off and on of coverage and related sort of migration of folks that move around a lot, and how either you've addressed them in the analyses or taken that into account, or even just as you've been planning the programs for the remaining uninsured, any insights you can offer on either of those.
So part of our, this is Alvaro, so part of our program, so the Contra Cares program, that's what we call our program. One of the key elements of it is really having the local health plan manage the assignments, if you will, of enrollees into the program. And so they work directly with the health centers so the health centers and the health plan folks would flag that are dropping, that drop from the program for whatever reason, either because they become Medicare eligible, and then that opens up another slot for a new participant to enroll. The other thing too is that we're trying to coordinate this program to track individuals as they seek services at the, that's an element of the program that we're still working on, and it really hinders on our ability to share information with the hospitals, the health plan, and the health centers. But I think that we're trying to address that, churning patients and patients that move around throughout the health system. So that's one way that we're looking at it.
Great. Any others would like to address that? Or the migration between regions, communities, counties? Okay. We'll move on to the next question.
Sorry, this is Susie. Going back to when we had the Healthy Kids program, we certainly did have to address when children migrated from one county to another and moved from one Healthy Kids product to another if there was a Healthy Kids product in the county they moved to. And so as we are beginning to develop these local programs for adults, I think we'll need to be cognizant of that fact as well. And then, and design our programs with some flexibility in them and make sure that we're where we have a lot of overlap between populations or populations that move across county lines, that we're thinking about that in advance. So that was certainly ongoing work when we had the Healthy Kids program. In terms of churn, there's always churn on and off programs, but you certainly, with a low-income population, have people fluctuating depending on where you set your eligibility level on and off of your program and into and out of other things. So, in this case, I think that would be in some counties CMSP, and other counties whatever their county indigent program is. And so, you want to make sure to plan for that in advance.
This is Julie. I would just add that when we identify an option, when we get to that point, we're definitely going to have to consider transitioning on and off programs, but we don't really know what that looks like until we land on an option. So that's still to come from Marin.
Great. So I have a question posed around SB 75 implementation going live in May, and it's, Susie, I believe you touched upon this start, and others can chime in. Sort of other than data, someone is interested to learn how preparing for this transition, and are you sort of experiencing any increases in enrolling undocumented children in restricted scope Medi-Cal in order to streamline their transition into full scope in May?
Yes to both. I mean, we've got a robust work group going that has a lot of different strategies in place, including getting out in the schools and meeting with all of the ELAC groups, which are the Spanish-speaking parent groups, you know, working with Migrant Ed, radio buys on Spanish language media, huge numbers of flyers going out to CBOs and community groups. You know, our process has really intensified to identify who are these newly eligible kids who aren't already in the current, touched by one of the current systems or programs, and find out who they are. And in most cases, we are enrolling them when feasible into restricted scope Medi-Cal. So that is what our plan is here, in addition to working through the tactical issues about how kids will transition from the other programs they're on, whether that's what remains of our Healthy Kids product and the Kaiser Child Health Plan, into Medi-Cal option. So we're working on all of those issues simultaneously.
This is Julie in Marin. We're doing some similar work through the Covered Brain Coalition, and with the help of our CHC, we're doing some outreach into these communities, and our FQHCs are mailing out to their families, and so we're kind of on a similar track as well.
Great. Alvaro, any thoughts from Contra Costa or Solano?
Well, in Contra Costa, we're working with the same group, our same collaborative, to really make sure that information is shared across the health centers and other community-based organizations that are serving this population. And so the California Endowment has made some investments locally to make sure that the word gets out and that folks are getting connected as early as possible.
Great, thank you. So maybe a last question to pose to each of you. Certainly you all are deep in planning. Some of you have moved towards implementation. Any last advice you would offer to participants on today's webinar about engaging stakeholders, building a collaborative, better understanding sort of who the remaining uninsured are in their local communities? Alvaro, I'll start with you.
Since I was emphasizing building an effective collaborative, I'll say that patience was really critical, and making sure that regular communication with your key leaders remains constant. I think having a small subset of the larger work group or collaborative to act as the primary contacts representing the different constituents was really, really important, and in building that trust. And I think, as I said, just patience is really critical.
Great. Susie?
Yeah, I think one of the things that can hang up a process is getting too much into the weeds with the data and numbers, and I think we, and what we're doing here in Sonoma County is just about the right level of involvement in that. I guess what we learned in the past when creating these kind of coverage programs is you have to know some important demographics and needs of your population, but you'll never, this is a difficult population to define, and you're never going to know everything you would like to know before you're, and if you try to do that, you'll never get to the place of developing a program. So find the sweet spot in terms of your research and data and what you can feel comfortable and confident with without spending the next 2 years doing research. I think that will serve everybody well.
Great. Brian, anything to add?
Yeah, so without repeating, I think I agree with everything that was said beforehand, but maybe just along the data front, I think one thing we learned is just be careful in making assumptions about the populations we're trying to serve. I think to Susie's point, a little bit of data can go a long way. So if you don't have the capacity to obviously to do a big study, at least try to learn as much as you can. Because I think what we have found, at least from our farm workers study and now this work, is some of our assumptions that we had were just completely wrong. And so I would say kind of question everything and kind of just take a look and just do a little, even if it's a shallow dive, just to make sure that what we kind of all assumed was happening with this population, and then a lot of it is correct. But there's little nuggets in there that are actually pretty surprising and important to know when you're moving forward with your endeavors.
A great point. And Julie?
I would just agree that having some good data, a baseline level, I guess at least, of data, knowing that it's imperfect, but starting with that, especially if you're trying to assess cost, you have to have an end there somewhere. And then the right organizations at the table. It's really important to have the hospitals, the CDOs who work day to day with this population, the FQHCs, those are all critical partners. And then I would say the last thing is having engagement at the right level, having the CEO or a high level engagement in the organizations, because things don't always trickle up, and really we need decision makers at the table for an undertaking as important as this.
Great. Well, thank you all for the questions you submitted, the conversation that was had. Today was really the start to what we hope will be ongoing conversations between the panelists and participants on this call. Just to remind you, today's webinar was the first in a 4-part learning series that the Foundation is hosting. The next webinar will be focused on benefits and financing, so what local programs are doing around benefits and financing. That will be April 14th. Then the next 2 will be eligibility and enrollment, and then measuring quality for program improvement. If you haven't RSVP'd yet for these webinars, we will be sending out an email invite in the next week so that you can RSVP for these webinars. Just wanted to say again a special thank you to Alvaro, Susie, Brian, and Julie for kicking off this learning series. We, as part of follow-up for this webinar, you will receive later on today a brief evaluation survey that we really would like you to complete to provide us with feedback on today's webinar and help us to continue our planning for the remaining 3 webinars. We also are recording today's webinar, and we'll make that available on the Foundation's website in addition to the contact information for the panelists today. So please leave today, continue conversations, learn from one another, and hopefully you will join us for the next webinar on April 14th. With that, we are out of time for today, and that will conclude the webinar. Thank you.